this world as a clinician, a speech and language pathologist, as Mark said, and I'm all about function and looking at function, myofunctional therapy, and learning about myofunctional principles has really taught me a lot in the relationship of structure to function and how that impacts development. So my background is in pediatric dysphagia. I've been a speech and language therapist for 32 years, and I've walked the boards in my profession. So I have passion. Before I retire, I want to share that passion and to influence public health. And I won the Winston Churchill Memorial Trust Fellowship with the aim of traveling to learn, return to inspire, and to look at shaking up and trying to influence health policy, and thinking about actually how multidisciplinary, multi-professional, integrated working practice really does improve the lives of our patients. So my learning objectives are to develop knowledge and to gain a deeper understanding of the impact of the relationship of function on structural presentation in a developing child, and explore this kind of interrelationship in terms of what's happening to function in a very, very young age, working with preterm infants who have had experience of intubation. They'll have had from that developed a high, narrow palate. As they come to discharge, we're involved in supporting feeding, getting children home safely, orally feeding, but actually observing the structurally compromised because they struggle with that tongue compression to support swallow and to support their nutrition. To recognize the relationship between the forces of compensated swallowing influencing the development of palatal arches and teeth development. Again, as a therapist, looking at function, and I was sitting in many pediatric assessments. No one ever asked about breathing. No one ever asked about sleep. It was always an add-on. And actually, you know, if you can address collective issues, you can create change through every walk of a child's life. And then to consider the clinical effects of anterior and posterior tongue tie on the 4 stages of swallow in the developing child. So the tongue thrust swallow, is an obvious force against the teeth, can inform bite and poor position. So I met this man, 35-year-old man, in my clinic, and he didn't know he had a swallow problem until he met an airway-focused dentist who referred him to me. He wanted to fix his teeth, and that was his assessment. So pushing the force, a disruptive force up against the teeth to inform the bite. And this is what his teeth look like. So and his palate, very high. And when I met him, he was chewing on one side. He was struggling with onset of swallow. He was compensating both orofacially, so using the muscles of the orofacial complex to get that driving pressure of force for swallow, but also recruiting all of the muscles of the larynx and around the pharynx to get force of pressure and strength of pressure. And sure enough, he had issues in the region of C1, C2, and seeking support from that pain. So this is what normal swallow looks like. This is what dysphagia therapists are looking at. It happens really quickly, and 0.72 of a second in an adult. And it's kind of, you see it, so you see it, it's the moving bolus through the 4 stages on its journey to the esophagus. You're passing through the hyoid area, through supported by tongue function, muscle movement for safe transfer of that bolus to where it needs to go. So the 4 stages of swallow, speech and language therapists, you know, we have to try and break out and identify something that's happening in 0.72 of a second into 4 stages. So you start off with the oral prep phase, the oral preparatory phase of chewing, where you're formulating the bolus, you're breaking down food texture. So when you think about a baby weaning, it's a backward-forward tongue movement to support that. It then evolves running alongside physical development to start to get stability to support increased range of tongue movement, and then leading to the breakdown of food, and you're then moving forwards. You're then moving forwards to the oral stage of swallow. But the next slide shows a little one who had a tongue tie, who had poor airway with his presentation. He was aspirating. You can see there he has a tube. And this was his swallow. And you kind of look at the increased effort to support the transfer of the liquid. He needs 1, 2, 3, 4, 5 pumping actions. It's in or discoordinated, and when you look very, very closely at that slide, he needed the tube to support nutrition, but he needed the tube to stop material going down into the airway. He was getting really poorly, and chest infections needed to be addressed. Okay. So this young man is a 9-month-old. He was weaning, and he was given a bite and a dissolved biscuit, so or a wafer, a crisp, and from here, the disruption at the oral prep phase was hard work. He needed to really work that texture. He struggled with restriction from a tongue tie to break it down. And it's taking a long time. And you think about weaning starts at 6 months for, you know, nutrition demands change, but weaning needs to happen at 6 months. And baby-led weaning, you know, is greatly promoted. But this little guy had real difficulties in breaking down food because of a tongue tie. Okay, so you've got the oral phase here, and the oral phase is when the food is broken down. You've got the food coming across the base towards the base of the tongue, and you then have sensory receptors at the pillars of forces which shift the swallow from the voluntary phase to the involuntary stage. And it's dependent on muscle movement, and it's very relevant. The tongue is very, very relevant in swallow because of its connections to the hyoid bone. And you have this action of the tongue tip coming up to the incisive papilla, ideally in the region of the incisive papilla, and then this suction that happens across the palate to inform the lift and elevation of the back of the tongue, which then creates change to the soft palate, lifting to seal off the nose, and you have the lift of the hyoid bone to inform the closure of the epiglottis. So there's a lot of activity going on. Okay, so the pharyngeal phase is a single pressure-driven event in which the oral cavity, the pharynx, and the esophagus form a single tube. The muscles pull together, there's muscle shortening to reduce the distance of the bolus, so it's directed and channeled where it needs to go. And the forward tilt and the movement of the hyoid bone, so as you can feel that lift and elevation, informs the opening of the cricopharyngeus to allow food into the esophagus. And that closure of the epiglottis just stops material going the wrong way. And then you've got moving into the esophageal phase. So when we're working in this field, you're looking at this is the norm, what stands outside of the norm. And I came into working and looking at tongue tie because one of my medical consultants, respiratory consultant, just said to me, why do we have so many children who are having chest infections, who have aspiration, poor chest health, leading to potentially bronchiectasis? Why is this happening when these children don't have neurological problems? So I was set up on a kind of inquisitive mission. We do video fluoroscopy, X-ray of swallow to look at swallow in detail to get a good diagnostic. And I spent time looking at the screens of these children and isolated difficulties into tongue position. And actually, it was the poor contact, the poor relationship of tongue to palate contact that was contributing to the muscles not supporting good swallow function. So you had material moving into the airway during swallow. So swallow is all about the relationship of tongue to palate, and it shapes the floor of the mouth, the tongue coming up, which affects craniofacial development, palatal growth, and teeth shape. So this young man, Alfie, just to share with you, again, it's thinking about dysfunction. He had a history of chest infections. We needed to manage those. But you can see from the slide on the left, you've got an upward movement of the bolus to penetrate into the nasal airway. So we know from that, actually, when a child comes to us and you hear bubbly breathing, what's going on with that breathing? Why is that occurring? Is that up in the nose, or is it in the airway, or is it resting in the pharynx? Because you've got to have those coordinated muscles working to keep the airway safe. So this young guy on the left, he's got material going up into his nose. So he has a lot of colds, a lot of phlegm. He was always stuffy. He was always poorly. And then, you know, on the right-hand side, you just see a poke of material during swallow going into the airway, and the line on the screen shows penetration. So again, I meet children who are young, maybe who 1.5, 2 years, who they're having to use asthma medication. And it's kind of like, is it genuinely asthma, or is it poor swallow leading to material entering the airway to set up respiratory, can't breathe, and they need that medication to keep their airway open. But digging a little deeper, it's all about actually let's figure out the problem. Let's support out health. What can we do to do that? So the studies that of interest, I am always a woman of detail. In the UK, I met a lot with tongue tie. It doesn't exist. We refer for tongue tie release, and it's not on the National Health Service health agenda. But there's studies coming out in clinical practice. When I meet with my colleagues, we're seeing children who have tongue tie, who have respiratory problems associated with the tongue tie. And this study just highlighted a child who was 21 months old. He had significant dysphagia, and they identified from their analysis poor base of tongue movement. There was poor strength of pressure and diffuse residue resulting in aspiration. So they diagnosed, assessed, treated the tongue tie, and his swallow changed. And he didn't have respiratory complications. He had improved base of tongue movement. Everything was fixed, okay? And that's powerful, and we've replicated that. So you think about actually as well, studies looking at position of tongue. Where does the tongue need to sit to start the mechanical movement? And this study just highlighted the strength of pressures starting at the inferior superior axis. You've got power strength at the posterior tongue. That's the power generator. So the posterior tongue has attachments into the hyoid bone, as I said. So if you have poor oral prep phase, if you have poor oral phase swallow, you're in for problems. You've got to find swallow strength somewhere else. Sometimes it's up against the teeth because I can't get my tongue lifted, or you've got compensation from other muscles. And it's where that compensation interfaces with structure. Okay, and that's another study that's looking at actually tongue position using a plate. So when we talk about aspiration and poor swallow, when we talk about aspiration and poor swallow function, this is what it looks like. It's a sketch, but you have that material entering the airway. So embryologic development, I mean, just going through actually the development of the tongue. Why do we have tongue tie? Why the features of anterior tongue tie, mid-blade, posterior, coming from the palatal arches and that early embryonic development. Whoops, excuse me. Oh, I'm so sorry. Okay, we'll move on. So there you go. So the embryology of ankylosing has come from this study, and looking at, again, the natural process of apoptosis, allowing the free tongue to develop. The embryology and fetal development is very important in swallow development, and there's studies to support that. Okay, so the work of Joan Arvidson, she was looking at developmental stages in swallowing and actually marking out pharyngeal phase swallow, the first motor response of the pharynx at 10 to 14 weeks. So true suckling is 18 to 24 weeks, and evidence by self-oral stimulation precedes sucking and swallowing. You have some thumb sucking. The tongue then starts to fill the oral cavity, and at this stage of development, and the frequency of sucking can be altered by taste, and suckling increases in later months of fetal life. By 28 weeks, a baby can tongue cup in normal development, and by 34 to 37 weeks, a baby can start to support their nutrition totally orally through amniotic fluid, and it's the exchange of that amniotic fluid that happens. So things are happening during embryology, during fetal development. And you have the emergence of, this study again looked at intrauterine studies as predictors for feeding difficulties. They looked at 62 healthy infants. They identified 7 infants who had unusual development, identifying as a type 2 on Arnold-Chiari malformation. You've got trisomy, polyhydramnios, intrauterine growth restriction. And they recognized actually that they could predict which group were going to have swallow function difficulties and, ready for the online support as they came into the world. So this just highlights swallowing amniotic fluid at 14 weeks. You have sucking in utero at 19 weeks, and then sucking in utero at 24 weeks as that fetus grows and develops. So by the time a newborn is delivered, you have that readiness with the tongue coming out. This is a newborn, the tongue coming out, ready for nutrition, and using their oral activity to support themselves. And this baby was just born. He did the crawl to find the mum's breast, and sucking was started. All of the readiness skills were all set, and good nutrition. Okay, so what does the literature say about tongue movement in breastfed babies versus bottle-fed babies without problems? Well, we know that breastfeeding is really good practice for craniofacial development, for extrinsic muscle movement engagement later on, for creating swallow strength pressures. But this study highlighted actually there was a lack of strength leading to material entering up into the nasal airway during swallow. So, you already have potentially issues with the engagement of the extrinsic muscles of the tongue. So So this is a young man who came into my clinic, and as you can see, he had his dental issues, and he came with a swallow problem, and he had many services involved. So this was the group of professionals supporting him. He had learning disability. He was about to go to school. They were choosing specialist school. He had attention difficulties. He had physical difficulties, sleep issues. Everyone collectively was involved. He came to see me for swallow. Okay, so what can I do with him for swallow without the backup of the professionals who are working in their lane? There isn't very much crossover, and very, very challenging. So again, he had an open mouth breathing pattern, struggling with sleep, showing signs of restlessness and hyperactivity. He came to my clinic and he was very busy. And from a swallow perspective, he had poor chewing, so that foods were only partially modified before being swallowed. So, you know, foods not being adequately chewed provide a choke risk. And there was coughing and choking at meal times and high incidence of respiratory tract infections. Everyone was managing him independently, not collectively. And actually the biggest piece, in my opinion, was supporting his high arch and his dental presentation. And without that, we couldn't get swallow strength pressures easily for him to change the course of his development to support that. So it's just emphasizing, and I think being in here today, it's about teamwork. It's about joining clinical thinking together to provide a good trajectory of care for a patient. So this shows pre-swallow, sliced banana, collecting at the low point in the valleculae, again, poorly chewed, and material stuck. Where's it going to go? Is it going to cause a choke risk, or can it be swallowed? And with tiring and fatigue, when the muscles don't work as good as they could, you get a choke. Again, this slide shows that poor strength to cause material penetrating and entering the nasal airway during swallow. So the integrity of the structures is important for function and best health. You have narrowing in the palatal arches. What does that tell us for breathing? You have high tongue posture, narrowed pharyngeal space. It gives us information about the palatopharyngeal muscles and actually the opening and the supportive freeway airway space for breathing. Tongue tie is a problem, and giving rise to where that tongue tethering happens, the movement around can cause a high presenting tongue, a low tone in the tongue. So from the evidence, we know if the range of tongue movement is restricted, it affects function for swallowing, and it leads to compensation patterns. So it leads to difficulties in supporting the control of the bolus over base of tongue, so you end up with a low point of swallow trigger, and you end up with airway issues. Strength of swallow is influenced by tongue to palate and base of tongue to pharyngeal wall approximation. So again, if you don't have strength, you're not going to be able to pass the bolus easily, so it leads to inefficiency. You need 1, 2, 3 attempts at swallow. Running with this territory is orofacial, reflux. you have issues from that repeated swallow taking down air to pass the bolus, setting up problems lower down in the final phase in the esophagus. You know, ballooning. Sometimes I meet children, we look at them under video fluoroscopy, and you can have ballooning of the esophagus where the muscles working in compensation create anatomical changes to the esophagus, where the muscle to the esophageal opening is overworking. So you get this ballooning, which can create massive problems. The swallow is led by the upward forward tilt. That keeps the airway safe, but that again can be disruptive. If there's a tongue tie, you can't get good base of tongue to palate contact. It's disrupted. It causes the epiglottis not to seal as effectively as it should, and reduced strength of pressure to support the palatoglossal closure, to support the soft palate. Again, disrupting pharyngeal forces, disrupting strength, leading to inefficiency. So this is another study, well, not a study, but just a video fluoroscopy study. You think from that lateral view, what about the tone of the tongue? You've got the uvula hanging down. It lacks tone. How effective is the strength of pressure going to be? So scores or assessments, looking at actually what's the space, looking inside somebody's mouth, the child's mouth. You can make some kind of basic predictions around what's going on here. What do we need to look at? So this is another case of mine, Henry, who came to see me age 2.9 years. He came with the profile of speech, breathing problems, sleep, attention difficulties, and eating and drinking concerns around the safety of swallow. He was presenting with right lower lobe chest infections, which is a marker for aspiration, contributing to the chest infections. So he'd spent time in and out of hospital, needing nebulizers, on oxygen. I mean, his history, he was born at 32 weeks, and he had increased incidence of poor respiratory health. He needed ongoing support from antibiotics, and again, the right side clinical presentation from illness. So this is him when I met him, and we looked inside his mouth. He had very marked tongue tie. He had a very high palate. And this was his video fluoroscopy. And I'll just show you the video fluoroscopy because it was difficult to establish what was going on for him because his swallow problems were subtle. This is a quick moving screen. But when you looked at what was going on, you could see a line of material going into the airway and contributing to those chest infections. I don't know if you can see that. Have you got a pointer, Victor? But you can see a very fine line of material going into the airway, scooting down subtly into the lungs and being problematic. Thank you. There's a very fine line. So this is another boy. This young man was a colleague's son who I met, he had a similar presentation to the previous child, and we needed to do video fluoroscopy with him. He came in with developmental chewing, swallowing difficulties. His mum said, yeah, he's always stuffy. He gets the odd chest infection, but you know, can we work without doing the swallow screen? And you know, sure, that's what we did. And nothing was changing. He still continued to get ill. So I took him to video fluoroscopy, and this was his screen posterior tongue tie release, and he had an adenoidectomy and tonsillectomy as well. He also had very narrow space at the back of the mouth. And you can just get a feel for the effort that's required. He needs to move his head backwards and forwards to support the movement of the bolus. His swallow is low and tipping over the base of the tongue, and he's got a ton of residue that's left behind from that reduced efficiency of the tongue making that contact to get that strength of swallow. It shouldn't remain. He goes on to deal and manage with further residue. So that was pre, and then this was post, and hopefully you can identify with, it's a little easier, the swallow. There's less movement. He still needs a little bit of work, but he's not moving around so much. He's not getting residue left behind. So his mum was very pleased. Okay. So the summary is, you know, you're thinking about the individual aspects at each phase, and it's all about, you know, very specifically dealing and managing with the food bolus and some of the issues that I've spoken about. So just moving through, when we're looking at myofunctional therapy, and I thank Samantha Weaver and Mark for sharing these slides, but you're thinking about actually, what does myofunctional therapy do? How can it help swallow function? Well, and all of the exercises, the muscle, all of the muscles of the face, the larynx and pharynx, they respond to exercises, and it's identifying actually in a very precise way at where that dysfunction is. And so this exercise, tongue into cheek, it's moving the tongue side to side related to swallowing. You want to prepare a food bolus, moving the bolus laterally to push it against the teeth surfaces to break it down. And this is what's happening from using a FEES. You've got movement from this lateralization. You've got movement in the pharynx, which is creating and aiming to increase tone. Blowing air into cheeks, again, movement of tongue base. You've got you know, work of strength. Okay. We've got the working the tongue with myofunctional therapy, having fun with the individual exercises to create magical change. We've also got blowing into balloons. You just think you're blowing into a balloon, but actually you know, as those slides have shown with Samantha doing that work, you've got increased activity of the muscles of the pharynx. There's been a number of studies working in resistance strength training and how by developing the muscles in the back of the pharynx creates change to swallow function. So a group of researchers looked at people with motor neuron disease, with stroke, head and neck cancer. Using resistant strength, they created change to swallow to reverse people's diet. So they moved from a modified diet, maybe a puree or a gastrostomy tube, to being able to eat food orally. So when you're thinking about, actually, we're only blowing up a balloon, it's that pressure strength that comes through to create increased tone. So myofunctional therapy for me has been an incredible journey. I would say that it's improved my patient population, so I deal with complex patients who are on tubes, and I would say that probably 70% of children, since I've been using myofunctional therapy, have come off tubes. So in terms of health benefit, it's a huge health benefit for a child's life, a parent's life, their emotional state, but also in terms of treatment costs, which is always of interest to the National Health Service health budget, but I have yet to convince them. And that's me. So thank you very much for your attention, and feel free to ask any questions.